I'd like to throw the first question out there to all of you. What do we know about the research of recovery, and can you translate that from your worldview into a description that a layperson would understand or recognize?
So if you'll permit me, I have 5 quick things to mention from NIAAA's perspective. So one is that we have recently operationally defined recovery for alcohol use disorder as cessation of heavy drinking and remission of DSM-5 criteria for alcohol use disorder. This is online. It's published in the American Journal of Psychiatry. It's online right now, and it'll be out in form soon. But we're hoping that that will stimulate some of the things that I just heard John Kelly talking about, which is ways that we can look at recovery and in some sense data mine across studies, because we'll have common elements that people can use as a metric. The other thing I just want to very quickly, we know social support, you heard a lot about that from John Kelly, is critical. We know that there's other social supports besides Alcoholics Anonymous. Alcoholics Anonymous works. We can talk about that later if you want, but Keith Humphreys has published some extensive studies supporting that hypothesis. And then, you know, they're promising things I'm sure Nora will mention, but everything from smartphone-based data to possibly neuroimaging down the line. And then what I used to call, because I remember Chuck O'Brien's group talking about a community reinforcement approach, but it's now called recovery-oriented systems of care. And I think Miriam will probably talk about that. So I'll shut up now.
Well, we're going to ask you back in on all of those points, but I thank you for giving us that structure. And Dr. Volkow, we were talking with Dr. Kelly about the reduced incentive to seek non-drug rewards and some of your seminal work. I wonder if you would talk about that and whether we have any approaches to sort of reorganizing the brain so that glutamate has a role in, you know, or reestablish pathways, the glutamate pathways, and their ability to help people focus on something other than the alcohol or the drugs.
Yeah, no, and thanks all for having me. And I just wanted to tackle though the first question first that you had, if I may, because I think it is, and it's certainly the Alcohol Institute has been ahead of us in terms of research for recovery. However, the circumstances for alcohol drinking actually are not exactly the same as some of the circumstances that we're currently having with people taking drugs. And so to start with, one is legal, the other is illegal, with all of the social issues that come with it. What we've come to realize from the research that is available is that we cannot speak just of one type of recovery. Recovery is a process, and it's likely to vary depending on the conditions of an individual. And just like we are actually learning to embrace more and more the concept of harm reduction practices that enable us to provide the type of support that the person needs where they currently are in their trajectory of addiction towards recovery. We're also seeing recovery in that vein. And as a result of that, we realize that what may be recovery for one person may not necessarily be for the other. So for an individual, recovery may be completely basically the use of drugs in ways that are harmful or complete abstinence. Whereas for another one, the recovery may be sustained treatment and strengthening of their recovery capital, support systems that will allow them to achieve ultimate recovery. And I think that, Andrea, you very well describe it. I mean, there is it is a continuous process, and so there is a stable recovery, but there are many stages before you get there. So from the perspective of what is it that we are prioritizing as a research institute, we've recognized the enormous need to start to develop tools that can be from measures that can actually quantify the different trajectories of recovery and how to quantify them, to provide support for researchers that are aiming to investigate this, and to tackle also areas where the evidence is stronger, and is definitively stronger for alcohol. For example, the important role that peer groups have in terms of helping recovery. So this is a less nuanced response than what my colleague and friend, Dr. Koob, has, but in a way reflects, as I say, the many social challenges that people that are taking drugs have. As it relates to your question about the brain, I wish I could tell you that at this point we know what is it that we can do to actually to improve glutamatergic systems that are dysregulated by the repeated use of drugs. We also know that it's not just glutamatergic systems, and when we're speaking about glutamatergic systems, the way that I like to speak about it is as an unbalance between the signaling systems in the brain. And one of the most important one is glutamate, because that is excitatory, but it's balanced by an inhibitory system, which is the GABAergic system. And the proper function actually of our brain requires those systems to be in resonance so that you can compensate for things that may happen. And downstream, those systems also are influencing different regions of the brain differently. And just as I was discussing about in terms of the diversity of the recovery trajectories, I also want to speak about the diversity of the changes and adaptations that occur in a brain of an individual that need to be taken into account. So it's not going to be as simple as saying, if I, for example, enhance the sensitivity to glutamatergic neurotransmission in individuals where it is decreased, or enhance inhibition in those where they have a deficit, but also in tailoring specific circuits. We cannot just go blindly into them. We know, for example, that one of the key elements that is involved in the adaptations on these glutamatergic systems, as well as others, that creates havoc in the brain of people that are addicted, are not just the effects of the drug itself, but also the stress situations that engender as a downstream from the changes that are occurring because you are taking drugs, and all of the disruption to your social system. So we've come to understand, and Dr. Cook has done really remarkably elegant work on this. I think he has been probably one of the lead persons on documenting how this stress is important. So, and as we're speaking about recovery, I mean, I want again to emphasize that notion of recovery capital that will allow a person to buffer some of those stressors. And I'm going to shut down here so that we have opportunity for others to give their perspective.
Well, and I'm dying to hear Dr. Delphin Rittman talk about the recovery capital and the translating that research into services and what goes on in the community. So I think that was a great segue for her.
Yeah. Thank you so much. Appreciate the opportunity to be on and to be able to be part of this discussion with my colleagues. So we've done, at SAMHSA quite a bit of qualitative, having discussions with community members around recovery, and also looking at the availability of the recovery research that's there. And we heard from John Kelly earlier that there is, there's a range of additional research that's needed in terms of better understanding, recovery programs and services and the impacts there. We know that there is a growing body of literature around the value of, for example, supported employment. And we know that is a recovery practice, and that can help in terms of people, advancing in their recovery. We've also used qualitative research, though, and similar to what Dr. Volkov has mentioned, some of the qualitative data suggests that there are multiple pathways to recovery, that people often describe many different processes, many different factors that impact their recovery journey and their recovery processes. And in fact, in terms of SAMHSA, our definition of recovery, in many ways, we've built on that, the fact that people describe a range of different processes at the community level that helps to advance their recovery. And so the SAMHSA definition of recovery gets at some of the social and ecological experiences that people have. And so we define recovery as a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. And so it sort of gets at some of the, ways in which people sort of connect within their environments and within their communities in terms of living self-directed lives. We've also used some of the recovery, again, qualitative information and data to develop 4 pillars of recovery and 4 dimensions, if you will. And those include health, home, community, and purpose. Health, home, community, purpose as the environments in which people connect and live their self-directed lives. And then have a number of guiding principles as well that often come out of the, again, conversations and some of the qualitative discussions. And some of these principles include hope, respect, culture, and again, multiple pathways to recovery. One last piece, one area of research that I've seen a bit of, I conducted some of it when I was in Connecticut or helped to fund some of it. We're seeing quite a bit of certainly anecdotal and some smaller studies that show that recovery coaches working in emergency departments and other environments, that there is some growing data there that shows that there's real value in connecting people to care, in helping with system navigation and system connection and giving people that hope that ultimately helps to create those bridges to other services and supports at the community level, to include sometimes medication-assisted treatment or other services and supports at the community level. So just a few sort of tidbits there in terms of recovery. Certainly a lot more research that needs to be done there, but a growing body and real promising practices certainly that we're seeing at the community level, whether it be supported employment, supported housing, recovery coaches, and coaching, as well as training of individuals at the organizational level. And beginning to think about and measure organizational level recovery. So recovery-oriented care from an organizational perspective, or recovery-oriented care from a system perspective, state system of care, for example, or a local organization. And that's an area where certainly additional research is needed. There are some measures that are popping up that get at recovery-oriented systems of care, whether it be at the organizational level or at the system level. We're certainly even seeing discussions around recovery-oriented communities. And so really exciting area, but certainly where more research is needed.
I have been in this field a long time, and it's really good to see so much agreement and congruence coming together. And I wanted to ask you, Dr. Koob, to respond about some of the work at Scripps that took place after the work in New Haven that looked at coaches or health educators in the emergency department and expanding the types of people who could bring the power of the health warning to create an intervention in the emergency department. Would you want to comment at all on the use of individuals at that point in order to create an inflection in that person's journey and to get them started on a recovery for focused journey rather than a drug using or an alcohol using journey? You might add to that.
Well, this is not my expertise, but Nora and I have talked about this in the context of multiple interventions that can occur in the emergency room, and that's the starting point. So, we need, even for someone who comes in with an opiate overdose and you give them naloxone, you're going to precipitate withdrawal. So, as Nora and I have talked about many times, we'd love to have a drug that could ameliorate that and start them on the process of recovery. Kevin Kuntz, who developed the ACAM and the board certification system that's now going throughout the United States for addiction medicine, his vision always was that there would be a SWAT team that would descend on an emergency room like you do if you have a heart attack. So if I end up with a heart attack, they take me to the emergency room, a whole team of cardiologists are going to come out and figure out what went wrong and fix it, hopefully. And, we need something similar to that, in my opinion, for addiction, whether it overdose on opiates, overdose on alcohol, overdose on cocaine, even people coming in on cannabis overdose and they're psychotic. So, I think the earlier you start and there is an opportunity. We're starting to look at that in the context of liver disease, where we see in acute liver problems, elevated liver enzymes, people seeking a liver transplantation. It goes that far. But we're seeing a window, and we're starting to work with what I call the liver docs on ways of identifying early interventions. And then, Nora, I'll pass it to you to talk about pre-addiction that you and Tom and I talked about. But I think it, in some sense, it dovetails into that construct as well.
Yeah, no, and if I jump into it, I think that what George is saying is very, very accurate. And we have many clinical trials now ongoing to develop and test models of care where the intervention is done in the emergency department as well as on patients that are hospitalized or just in primary care. For the emergency department for hospitalization, and as Dr. Kuhn wanted and was predicting will happen, one of the most important things that you can do as it relates to someone with opioid use disorder is to engage them and to initiate medications for opioid use disorder, because that will protect them against overdosing again, which will protect them from dying, and they're very effective. But that in many ways has been challenging. And the same thing with patients that get hospitalized because they need to have a valve replacement, and the ability to do an intervention there in the healthcare setting, whether emergency department or inpatient, is a unique opportunity, but we're not taking advantage of it. And that's where actually the addiction council, so it's having access to addiction consults becomes so very important, but it's very unfortunate. My understanding is to start with very few emergency departments have access to addiction consults that George was mentioning too. And also even in the hospital itself, a very relatively small percentage of hospitals have access to addiction consult. And this actually has to be integrated. And again, we're seeing more and more these models of integration of care, because it's not just in terms of providing the medication, but ensuring that the person will basically be retaining treatment and that they can be actually incentivized to go into changing to a healthier lifestyle, which is the first step towards recovery. And that's where peers play such an important role. So throughout this research network that we started in 2020, NIDA has created a hub associated with researchers all over the United States to try to get insights of models of care that are linking through recovery and that are using both addiction consults as well as peer navigators and coaches. There is very little research on this space, and I wish I could say that it's more. And then finally, for primary care, which is what George was alluding to, because we had a piece together along with Dr. Tom McClellan, where we strongly basically brought up the concept of encouraging an idea that's basically inspired by the pre-diabetes concept in 2000 that led to the coverage and screening of individuals that are at risk for diabetes to actually be able to give interventions to minimize the risk that the trajectory ends up in diabetes. And we are encouraging this concept. We're floating it around in the communities, because one of the aspects that is we definitively need resources to make recovery a reality. And currently those resources are quite limited. So how do we generate a momentum that will provide an infrastructure to support that through the pre-addiction concept? Pre-addiction concept is one that we are proposing that could help start to cement the identification of codes in order to be able to reimburse for the active engagement in recovery. This is an area also that is going to be key that we involve policymakers, because that ultimately are going to establish the models of reimbursement. Because if, for example, you are in the emergency department and you just get a fixed reimbursement for, say, reversing an overdose, and that's it. And in that one, you have to include initiating on buprenorphine, and you have to include engaging with a recovery coach or an addiction consult. That's not going to be incentivizes the hospital settings to do that. And so I think it is going to be, this is an area that requires a lot of attention, and where we are hoping through this recovery research network that we've created, build up that data that will inform policy and that will help guide best models for care. And I'm going to shut down now because I've spoken a lot.
Well, we started out by talking about the commitment of the bench to trench that NIH and SAMHSA has shown in its working together through the clinical trials networks and the technology transfer work that you all have collaborated on for now over almost 2 decades. So I wonder, Dr. Delphin-Brittman, if you talk a bit about the kinds of services that have been developed where some of these things might be tested to create these models of reimbursement for us that's to support recovery.
Yeah, no, thank you for the question. I mean, one certainly is, in terms of the, recovery coach in the emergency department or recovery coach in, different clinical settings. I mean, that certainly is a service where, as I mentioned previously, we're seeing at least anecdotal and some data that is showing impacts there. I can speak a little bit about some of my previous work in Connecticut. It was actually funded with SAMHSA funds. And so thankfully the state opioid response grant, so SOAR, we were able to fund emergency departments in 20 emergency departments across Connecticut. And some of the goal of that work was where people end up in an emergency department with, as a function of some substance-related emergency, the coach would then work with them and connect them with other services and supports, working with them over time. And some of the initial data from that study showed that the coaches had over a 90% connection rate. And looking at a period of time, individuals who had a coach versus those who didn't have a coach had less relapse and fewer returns to the emergency department. Using Medicaid data. So we tracked Medicaid data, and that study is ongoing, and SOAR is continuing to fund some of that work. But other programs, I think that certainly could be evaluated and are certainly that Medicaid reimbursement. We have our 988, and so 988 is our new initiative around the suicide prevention lifeline. Crisis services, the mobile crisis services that are available there are not only for individuals with mental health related crises, but also substance use related crises. And increasingly, we're seeing state teams that include individuals in recovery. So peer support workers or recovery coaches as part of the mobile crisis teams. And again, provide a real valuable role in terms of connecting with individuals and providing hope in terms of the recovery experience and connecting with services and support. So I think that's another model that there's opportunity for reimbursement potentially, and an opportunity for additional research to better understand the value of recovery coaches working with mobile crisis teams to help connect people who are experiencing substance-related emergencies. And then one last model in terms of, there's opportunity for reimbursement, but also involvement of recovery coaches is our certified community behavioral health clinics. So these are clinics that are, we now have 430 of them around the country. They offer wraparound services and supports, typically under one roof, but sometimes there are collaborative models as well to offer 10 critical services, which include recovery coaching, crisis services, mental health services, substance use services, groups, so a range of wraparound services. And again, through the CCBHC model, there is an opportunity for reimbursement around different components of that care, as well as research in terms of looking at the value and the impacts that we're seeing with recovery coaches, at least anecdotally in that model, working across different levels of care, whether it be mental health supports or substance use related services, crisis services, and even connecting in terms of other medication-assisted treatment. So we're seeing recovery coaches also working in methadone clinics as well that connect with the CCBHCs. So those are just a few examples of, I think, areas where there's opportunity around enhanced and additional reimbursement, as well as research in terms of the value of the recovery work.
Thank you. One of the questions that we asked that you think about in preparation for today's panel was the state of recovery services in the United States 25 years ago versus today, and to reflect on what's changed from your perspective. sort of to do a survey of, what's been like, what it's like now. And then we'd like to talk about what you see as needing to develop in order to really embrace the differentiation that we've put in the treatment and demand reduction continuum from prevention, brief intervention, harm reduction, treatment, and then recovery. But what's the last quarter of a century shown you?
Well, I mean, one thing we found is that screening and brief intervention, referral to treatment actually work. The problem is, and we have a number of studies now that illustrate this, is that we get screening, something like 70–80% of individuals are asked about their alcohol intake, but there's no intervention and no referral to treatment. It's virtually nil. And so this is a big part of what I call the treatment gap. And, in the emergency room, I think just to take a step back, you have a captive audience and a serious problem, but the doctor's office, you don't. And so, I think we're working, it's going to be a big push for us that we're going to try working on how we can get more individuals to do the intervention and the referral to treatment. So that's 2 cents from the Alcohol Institute.
So I'm going to ask for 2 more cents in a minute. You might want to start thinking about that in advance. You sort of touched on it earlier. You've been able to show, and John Kelly talked about it too, that AA works. What else are we looking at for people beyond AA? But Nora, Dr. Volkow, how about you? What's the last quarter of a century shown you?
Yeah, and I was going to say, I'm dying to also get the perspective from Dr. Dolphin Rittman, because they are the organization that has been actually providing the infrastructure to allow for this. But I can tell you both from 2, I'm going to answer it 2 perspectives as a psychiatrist that have been actually addressing substance use disorders themselves and studying them through research. But the other one as the director of NIDA. And as a psychiatrist, when I actually was in training, I remember a big impression that Dr. McClelland gave a lecture that made a big imprint in my brain. And he was challenging us to try to figure out what was the worst outcome. An individual that has had a chronic history of alcoholism, but it's basically has been able, even though it is extraordinarily severe, has years of drug use, alcohol use, has still been able to maintain a family and a job. And then she says, or an 18-year-old girl who basically had just was thrown out of her house, has a history of 1 year of drug taking, and is now living in the streets. And I think that those 2 cases illustrate the aspect of what I, as a clinician, have come to recognize, and also as a director of NIDA. And that is the notion that it's absolutely correct that addiction is a disease of the brain, but it is basically driven by social factors that either make it easier to transition and to get out of it, or that actually make you increasingly more vulnerable. And because there are these extremely important social factors that can be the difference between ending up with a severe addiction that is not going to actually be able to recover, or one that we can, the recognition that we need to put resources to strengthen that recovery capital. And those are issues like basically providing a safe home for persons to live, giving them a profession. I think Dr. Dolphin Rittman said it very well. You have to give them health, you have to give them home, you have to give them profession, and you have to give them a mission. And those factors are fundamental. So as we are moving into the recovery research network, we are interrogating specifically the impact of this factor in the success rate, as well as the models that we can use to provide it. Again, with all of the granularity of diversity of which these individuals end up. And just to make the story short, I mean, from that presentation that Dr. McClelland said, and I was very unfortunate because, of course, it is that the outcome for that young woman was very, very poor. And was very poor because of the lack of social support systems. And meaningful social support systems are some of the most powerful protective factors that we have. And so in recovery, we need to figure out how we're going to be building them and sustaining them. But I want to hear Dr. Riedman because she's the one that really is her agency that's working with this.
Yeah, no, thank you. Thank you. So we, I think the last 25 years, we really have seen, I would say, just an explosion in terms of the recovery work in wonderful and really creative ways. In fact, we did a recovery innovation challenge, through NIH and received 350 applications. I asked to be part of the review team because I just wanted to see some of the work that's out there across the country. And my goodness, such creative work. And even recently, as I've begun to sort of do more, anytime I'll do a conference or try to visit some of our programs that we fund. And so, for example, we see drug courts that employ individuals in recovery, so that have recovery coaches and recovery support specialists that work with individuals that are connected to the justice system and help them navigate their way through, whatever their trajectory is, sort of based on their recovery and based on their connection, with the drug courts, and just such innovation that's happening there. Many of the drug courts, again, that are heavily staffed with individuals in recovery, are like CCBHCs, or like community health centers, connecting people to housing services and supports, to employment services and supports, and then sometimes those employment services and supports, some of which were SAMHSA funded through block grant or other resource, then those programs also have recovery coaches and recovery support specialists that are helping people connect with employment or housing or other services. And so really quite a proliferation, I would say now, of recovery services and supports just across the board. One thing that we're doing in terms of our grants, we've added language in our both mental health and substance use grants around incorporating, recovery services and supports as part of the grant as an allowable expense. And so it's allowed for just quite a bit of creative sort of thinking and programming at the community level in terms of involving individuals with lived experience across a broad range of community-based programming. We see recovery drop-in centers that are of real value, and those centers themselves also end up looking very much like community health centers, connecting people to housing, employment, healthcare, sometimes medication-assisted treatment, often have Narcan on site. Very much, in many ways, community health centers, it seems, unto themselves. And so it's just wonderful to see the range of creative work that's happening at the community level that has helped to expand some of the recovery work beyond some of the traditional groups that we saw, self-help groups or mutual aid groups that we saw, 25 years ago. And those groups are so important. We know that those are vital. So it's wonderful that those have continued, but now we see a range of other services and supports, recovery services and supports that are available as well at all levels of care. Recovery coaches and support specialists that are part of clinical teams within community mental health centers, that are part of methadone centers and methadone teams. And so quite a broad range of work where recovery is part of that work now.
Thank you. Dr. Koob, your hand's up.
So looking back 25 years, another piece that really is the follow-up on what Nora said is the recognition that that addiction is a brain disorder, and that there are circuits in the brain that may look like they've returned to normal, but when the organism is stressed, even a year later, 2 years later, those circuits have been sensitized. And when I'm talking about our brain stress circuits and the stress system in the brain. And we've come to learn a lot about this. We've known for years from the time of Alan Marlatt that 2/3 of relapse in alcohol use disorder is due to negative emotional states. But I think more and more the concept of allostatic load, of allostasis, that you're putting weights on the system from the social perspective, as Nora pointed out, means the brain is also changed and staying changed and staying vulnerable to relapse. And I think it's as I think John Kelly said, a biopsychosocial interaction. And I don't think we should forget about the fact that there may be ultimately ways of reversing that biopsychosocial allostatic load. And for example, exercise, you wanted to know about glutamate and dopamine and all the transmitters in the brain that can help you out. Well, regular exercise can help in that way. And I'm not suggesting that's a cure-all for addiction, but it can be part of the process, just like getting a job, having a meal on a regular basis, and interacting with other human beings, which is an incredibly powerful reinforcer that reduces all the bad guys in your brain and brings out all the good guys, to put it simply. I hope you like that, Nora.
Yes, I love it. So I would say that treatment would be actually, let's surround ourselves with good people and let's get rid of the bad people. I think that's supportive. And I think that the point that I wanted to make within this whole concept that I'm making is as a joke, because it's really not a joke. We want basically to address that issue. We need to get rid of discrimination. And that was a point that I think that we're still discriminating enormously. But I think at least during the past 25 years, there has been an openness and a recognition that the stigma and discrimination against addiction is actually making the whole issue much worse. And in parallel, there's been that recognition that criminalizing the drug user or actually dealing with addiction by incarcerating is probably one of the worst interventions that we can do, because you are degrading the recovery capital. You're making it negative, going to the red. So I would say that there is a keen awareness, more of an awareness. They're still very polarized. I still have to battle a lot of people that have very stigmatizing views about addiction. And I do want to highlight it because in recovery, it is crucial. And I wrote a piece about it because it just struck me exactly what Dr. Cook was saying, how negative stressful is to our brain. And again, looking into my own experiences as a woman, as an Hispanic person, how terrible it is to feel discriminated. It's painful, it is, and it's painful in a way that it's not, you hit yourself and then the pain. It's the pain that lingers and that affects the way that you're going to be interacting. And so that's why I've become, to me, is that an extraordinarily important aspect. If we want to achieve recovery, we need to succeed in getting rid of that discriminating perspective that we still hold as a society against people that take drugs that are addicted, and how we treat them or basically neglect them.
I really appreciate you saying that. We've dealt with peer pressure as if it's some amorphous thing that weighs down on kids, and we found that it's very intense and personal in peer groups. And we've dealt with stigma as if it's this amorphous thing that weighs down on people who use drugs, but it's really the discrimination that is allowed to exist and be directed at the person who is stigmatized that, creates more harm than the stigma itself. And as you begin to peel back on that layer and think about the things that we tolerate that go on that are directed at people who use drugs, how more difficult it makes it for those individuals to thrive, health, home, community, and develop a purpose. So I appreciate that. But, I sent you the question about the areas of policy that are being either impeded or expanded in harmful ways to people because of the existence of stigma. And I quoted you, Dr. Volkov, saying, as a society, we still keep addiction in the shadows, regarding it as something shameful, reflecting lack of character, weakness of will, or even conscious wrongdoing, and not a medical issue. Can you talk about how, the basis for your saying that, and how you believe that either impedes policy development that's going to make it easier for people to recover, or allows very harmful policies to be developed and implemented that are directed at people who use drugs?
Yeah, and again, there was something that Dr. Rittman mentioned that resonated in my brain, because I think it is a very good way of describing recovery. And that is when you are self-guiding your life as opposed to letting the drugs guide it in automatic behaviors. I mean, obviously, in many ways, that is much easier for all of us that have a structure and we have a purpose, and everything is basically, not that everything is taken care of, but we have a very good likelihood and plans on how to take care of our needs. When you don't have that, and on top of that, you've grown in an environment where you are discriminated, and you start to internalize that discrimination, and people that actually become addicted frequently have extraordinarily low self-esteem. And this is basically really opposite to what we want them to, what we want to give to them. We want to be able to empower them. We want to be able for them to start to trust in themselves. And again, if you are continually stigmatized, criminalized, that's very, very hard. And that's why I very specifically said that. And I think that, again, I was sort of saying it jokingly in terms of how because as a society, and certainly with Hollywood, we want to look at good guys and bad guys. And so, but we do tend to polarize this situation, and negative interactions, discriminating, stigmatizing interactions really degrade, exacerbate the nature of the problem, just as meaningful and caring and compassionate and respectful interactions embolden people, and it's a key step for them to be able to start the road of recovery. You need to believe in yourself.
Thank you.
Another aspect of this is words matter, and we have, all of us, been engaged now in trying to change our language so that, you know, we make it more person oriented and less stigmatizing. But I think it, and you probably are going to think by now that Nora and I do nothing but write opinion pieces together, but there was another one with Josh Gordon where we wrote about this for neuropsychopharmacology. But, you know, I think this extends even into healthcare systems, and I don't want to pick on them, but, you know, if a patient comes in who's obviously intoxicated with alcohol, they're likely to be shunted off to another corner of the emergency room and neglected for hours at a time. Or snide comments are made to other healthcare individuals. Oh, you can leave him, that's Joe, he always shows up on Friday night. And you know, I think we're doing our best to drop words like abuse and alcoholism and you know, addict and so on and so forth. And, you know, it sounds trivial maybe superficially, but it actually is, I think, really important.
It's an example of how the healthcare community stigmatizes, and there may be some cause for it. We had a patient in our office who couldn't get on a transplant list at one of the Chicago teaching hospitals because he was actively drinking. And he came in for outpatient care, and, you know, we sort of loved him until he could love himself, treated him, and he got on and off the transplant list as a result of stopping drinking because he had recovery of his liver after he stopped drinking. And it's just so much power. The recovery is so powerful in being able to transform health, life, and otherwise. And, you know, while NIAAA was responsible for the small pamphlet that became Screening, Intervention, and Referral to Treatment, which was a, you know, $20 million small project funded by SAMHSA when Curry was there, it was NIAAA's work which enabled that. And as you say, it is now a standard and routine policy, but it doesn't, if it doesn't go to completion, we still have work to do. And I'm hoping that you can talk about that, but we keep getting some questions from the audience that says they want to talk about the peer recovery support. And I just want to make sure I get the potentially beyond providing linkage to services, but other ways in which they can help to address the treatment gaps. In prior panels, we talked a little bit about whether it puts someone at risk if they're early in recovery to work with people who are actively using, and you may have opinions about the full spectrum of things that relates to the peer recovery workers. Any of you, we'd love to hear.
Well, I'd like to hear from Dr. Dolphin because one of the things that he said, and we have testified together many times, and this has also made a big imprint in my brain, said that how important it is also to train the workforce, and that also includes recovery. So I'd love to hear
Yes.
what he has to say on this.
Yeah, thank you, Dr. Volkov. So, I agree. The training part is absolutely critical. And in fact, SAMHSA, we're currently working on, as part of the president's, mental health strategy, there was a component in there around developing core competencies for, recovery certification training. And so we are in the process of developing a model certification competencies around recovery training, really reviewing a lot of what is out there, looking at what are the key domains, the key competencies as it relates to, training individuals around recovery support services or recovery coaching. Many states have models at the local level. And so some of what this work will do is, looking across those models, but also having conversations and doing some focus groups with states that have certification programs currently in place. So the training certainly is important of the peer workforce, but also the workforce that will ultimately supervise recovery coaches and individuals in recovery. And so, recovery supervision training is important, and then recovery leadership training is important to the extent that individuals in recovery, can have a trajectory within a healthcare system, and working with individuals around what they, how they envision their trajectory within that system, what they envision that to look like, and ways to get there. So yes, the training piece is absolutely important. And some of what we'll be looking to do through our Office of Recovery, which we announced about a year ago, and that we're currently in the process of staffing and standing up, is certainly looking to work with states and around providing recovery training opportunities, recovery and technical assistance. We do have a couple of recovery centers of excellence that provide training currently across the country for recovery organizations or organizations looking to implement, recovery-based services. But yeah, the training piece is absolutely important.
I am thoroughly impressed by the level of collaboration. You talk about, Dr. Koob, how it seems as if all you're doing is writing with Dr. Volkov. I mean, I think it's tremendous that we have unanimity in an area that we needed, and how we've evolved so much in the last 25 years with that. It speaks to the consistency of leadership there, and Dr. Volkov, how well you're working with SAMHSA, and how you recognize the contributions that the providers who receive funding through SAMHSA make towards translating into real services the kinds of knowledge that we get as a result of the work of the institutes. And it's incredible to watch. I've come to the end of my questions, but the audience have been sending questions forward as you've been speaking. And Mimi Miscali at Forest Marsh Group has combed through those questions, and she has one for the panel. So go ahead, Mimi.
Yes, so this question speaks to the idea of getting reimbursement for these kinds of services that we've been talking about. How can researchers help to support getting this kind of reimbursement?
The way that I view it, I mean, and again, in general, in terms of one of the goals for the Institute, is what data can we generate that can help guide policies. So in this case, the data that we need to generate is to show that providing this support that is necessary for recovery leads to significantly better outcomes, and to actually include an economic analysis of those outcomes and costs, as well as the costs that have been averted by achieving recovery. So to me, this is a key piece so that it can be presented and and can be used as a justification for requiring reimbursement for these practices. Because I am afraid, and we've seen it all along in healthcare, if there's no reimbursement, an initiative can show benefit, but it's not going to be sustainable in the long term. So my view right now is that we created this research network, which its purpose is actually to build up on the evidence of different models of recovery, as well as the cost associated with it, and to provide an infrastructure that will allow researchers to investigate it. And as I said, this is a research network that we started in 2020, and it's going to be crucially important that we partner on this, absolutely, with SAMHSA and with the Alcohol Institute. It goes without saying, and I will hope that data will allow to inform on the need for reimbursement practices, because right now the data is very limited. And knowing my experience when we asked, for example, to get reimbursement for screening and brief interventions for substance use disorders other than alcohol, it was deemed that the evidence it was insufficient to basically justify a recommendation. So we need to fill that gap.
Thank you. Any other closing thoughts?
I just want to make it clear that we love SAMHSA too. Okay, so you know, we use the SAMHSA locator in our AAA treatment navigator, and we have a good relationship with them. I just don't want to make it, you know, I mean, I don't want them only dancing with NIDA. They have to dance with us too. So.
Well, I know, I haven't been on your council, that you love them, and you haven't been able to get a word in edgewise to bring them in, because Nora has been there ever ready. Whenever she gets a chance to finish talking, she brings them in. And if she hadn't been ever ready, you would have been bringing them in. That goes without saying.
No, I'm mainly joking, but I did want to make the point that all three of us work together whenever we can. Yeah.
That's true. Our teams have regular meetings, and I appreciate when we have our meetings. So absolutely. I mean, the synergies there are critical, and it's been wonderful, the various collaborations that we have. So
thank you.
Yeah.
And thank you all for being here with us at this very important conference. You know, as a result of the last one, when we opened, we've noticed that there's research portfolios that are dealing with recovery, and we're grateful for the attention that this group has garnered with the people who are in these positions in Washington, and we appreciate your coming over this afternoon and spending this time with us. Thank you so much.